Hello again. Thank you for the great feedback that you've been sending. We are now on to chapter 5 of the series, where we will talk about some advantages, some limitations of flow cytometry. I'll make some acknowledgements, and then we will also talk about the uniquely Iowan story behind this hashtag, Go with the Flow. And of course, we will end with a few cases. If you have not seen prior chapters, I would encourage watching chapter 4, at least, before embarking on this one. So, as you might have guessed from the prior video chapters, flow cytometry has many, many advantages. Of course, I'm biased. It's a very rapid testing procedure. So by rapid, what do I mean? In general, you should be able to have results out within hours. If labs are not getting results out within 24 hours of receiving the material, then it may be time to look at the process, where the bottlenecks are. It should be possible within a day to have a flow cytometry report back. Or if you're integrating that information into a bigger report, then at least have that information there to be integrated later. Flow cytometry is a very sensitive, very specific diagnostic test. Of course, it is great in monitoring of residual disease, minimal residual disease. And this in itself is a big chapter. What's the best way to approach? In some situations, it might be another test. But where you can find aberrancies and patterns, flow cytometry remains a very powerful tool for finding residual disease. And sometimes flow cytometry may be your first clue to determine some line of investigation that you may not have thought about, be it some type of genetic test, cytogenetic study, that sort of thing. So while this is an awesome procedure, it does have specific limitations. Sometimes I hear about cost, and it may be true in certain systems, just the implementation might be difficult across the world, or it might be thought of as an expensive investigation, particularly with out-of-pocket type systems. And there one can argue a long time whether it is costly in the long run or it is a good test to get upfront so that you have the right diagnosis right away and then can save on many missteps along the way. Now, some specific limitations. Tumors composed of large friable cells are an issue. Sometimes during the processing, these cells are not going to make it to the final suspension that is stained. And so that's a limitation. Hodgkin lymphoma, you may be able to detect it in initial tissue, although it's not the mainstay of diagnosis. And particularly for staging marrows, if you know that there is a diagnosis of Hodgkin lymphoma and the bone marrow was done purely for staging, flow cytometry does not have much of a role. In the initial lymph node where the patient does not have a diagnosis of Hodgkin lymphoma yet, obviously it is best to have some specimen available for flow in case it turns out to be a non-Hodgkin lymphoma. With myelodysplasia as well as myeloproliferative disorders, flow cytometry does have a role in potentially suggesting or diagnosing these disorders. But the most important thing to remember there is a negative flow cytometry study does not rule out these disorders. So that's important. These neoplasia may be missed by flow cytometry. Plasma cell myeloma, the main thing to remember there is it is good for the flow lab to know of your suspicion of plasma cell myeloma or a plasmacytic disorder in general, because then you can get a specific panel that includes intracellular light chain studies. And then in my introduction, I told you about the more the colors, the more the parameters you can measure on the same cell, the higher the diagnostic accuracy. But this is arguable as you get into beyond 10, 16 color situations. Just the technology and the difficulty with the compensation and how to get around it, there might be a diminishing return of having more and more colors. Although if you can technologically get it done, if you can have 30 colors, you may be able to make powerful diagnoses on very paucicellular specimen. But there is a diminishing return. Sometimes almost everybody who has switched to 10, 12, 16 color flow cytometry yearns for the day of the very stable workhorse 4-color, 6-color type machines, just because of the complexity of the data. So those are some of the limitations of flow cytometry. And of course, one of the limitations is the analysis is approached by many different ways across many different systems. You already know my bias about cluster analysis, but the reality is that there is, while cluster analysis is one method, which I'm powerfully promoting, many different ways can get there. As they say, there are many ways to skin a cat. I don't know why they use that phrase. Maybe I should say there are many ways to make a biryani, only one or two really correct, tasty ones. And the main thing there is get into the pathologist approach, approach the raw data yourself, whether you're doing it through a gating type software or whatever. Don't have a situation where there is one mastermind that has set up all the gates and everybody else is simply following that. It is far better, particularly as residents and fellows, to play with the data yourself, draw the gates yourself, make those decisions yourself, and then compare what is the best methodology for you to find these populations. So that's where I'll leave that. In terms of acknowledging, many people have contributed to my interest in hemepath and flow cytometry, as well as the success in implementing these types of approaches. Lots of faculty colleagues. First, I have to thank my generous mentors that I've had over the years, particularly for this area. I would really thank my PhD mentor at Northwestern, Steve Miller, who exposed me for the first time to a flow cytometry machine where I could play around with many things on the research end. And then an equally generous mentor at UT Southwestern, Robert McKenna, who was my hemepath fellowship director and now friend, philosopher, and guide after that. So in that environment at UT Southwestern, I've already mentioned Louis Picker, a visionary flow lab director who brought in this cluster analysis concept. But then we really honed it while overlapping over there with Steve Croft. And I would be remiss not to mention the super enthusiastic Franklin of Buddy Fuda, who was my fellow there, now is the director of the lab. And we really honed this technique and panels and everything together. A lot of residents and fellows over the years have had an influence on me. I particularly want to thank the current Iowa resident clan who is so enthusiastic supporting this whole venture of getting these lectures out on YouTube and Twitter. I'm getting comments on it every day, so thank you for that. And thanks for everybody else's feedback too. Members of all the clinical flow labs and research labs and collaborators that I've collaborated with on projects over the years. And then of course, funding agencies for the research where we heavily use flow cytometry as a technique to answer immunology questions, and also do lots of projects within the diagnostic flow realm. So one huge thanks, after starting this thing on Twitter only a few days back and recording it on YouTube, just today I noticed that we have had 1,000 views, completely unexpected, on the very first flow video. This is being picked up in various countries as part of educational enterprise by societies. So it's been extremely gratifying for me, completely unexpected. My personal YouTube channel now actually has subscribers, and I have to sort of think through that, what that means. But this keeps me inspired and going, making all these videos. At some point, you guys will get tired of them and then will tell me to stop. So what about this Iowan story that I've promised that I will talk about? So, you know, first time when you read the hashtag go with the flow, you probably thought this was great sage advice coming from a guru telling you to be equanimous, calm, and composed through life. And it is great advice in tight situations. If you can just step back and say, go with the flow, might make that day easier. But here we have a different story. It started with a Friday CP morning report in our program. Every Friday morning, 5 or 6 residents who are on CP rotations will present, 10-minute vignettes, cases. And about 2 years ago, Joe, right here, who's now actually one of our chief residents, was presenting a case, and the way he presented it was great. In his typical style, he talked about him being on the wet side of heme. So on our heme rotation, we have the wet side where residents are doing either differential counts or looking at smears as they get referred for morphology. And Joe was looking at this late evening smear where he was noticing these cells. And then he talked about also noticing these larger cells, which apparently got him sweating. So he described that he was worried about these, and then he made the case in such a way that eventually flow cytometry and cluster analysis provided the great answer and saved the day. And so it actually turned out to be a case of Richter's transformation, if I remember correctly. And so since that saved the day, we discussed, okay, so what was the moral of the story? And I thought the moral of the story was very simple. And we ended that CP morning round saying, okay, this is the principle to follow, that when you're wet with sweat, just go with the flow. And I thought we had a great chuckle and it was done. But turns out that same Joe stepped in the next week on a Friday and presented yet another case of where he was wet with sweat. And this time he knew exactly what to do, because right there, on the glass, on the wet side, was pasted by Joe this great principle: when you're wet with sweat, just go with the flow, right next to the instructions of how to remove oil from the slides before putting them back. So that sort of became our motto on the wet side of heme. And not to be outdone, almost a year later, we had Rob Humble, another resident in our program, who formulated the humble evolution of that sign, or I should say not so humble, because he presented this at CP Morning Report, where deriving from what I can call a marketing campaign by the university, where they were recognizing several scientists and leaders across the system. And there was this billboard and newspaper ads that they took out. And what Rob pointed to was this little principle that was written right next to me. And he imagined it as being, when you're wet with sweat, just go with the flow. And so this sign has now achieved a major upgrade, where he has pasted this on that same glass window. So jokes aside, I guess when you are wet with sweat, it's a great idea to go with the flow. And that's our University of Iowa story behind the hashtag. So let's go with the flow. Let's do a few cases, maybe 2 or 3 cases to keep it short. And for that, I'm going to stop sharing this and move on to this view right here. I hope you can see. I did receive some comments back that on smaller screens, you have trouble seeing these axis labels. And so I'll try to slow down and tell you what's on the axis, but I don't promise it, because I do get excited when doing cluster analysis. So we'll do 2 or 3 quick cases and then stop for this video. Here's one case that has come in for lymphoma evaluation. It's a tissue, a mass. And we have this B cell tube that we will start with. So again, this is CD19 versus forward scatter. So you can see that here's a B cell cluster right here. Just eyeballing it seems like the B cells are splitting here into kappa lambda, and here are the B cells as well. 19 and 20 positive. So let's see what happens when we paint them. So let's pick a color. Let's say green, so it might show up better on the screen. And you can tell that this cluster, including these medium-sized large cells, unless it's all junk, seems to be B cells. So let me take away that highlight. Okay, so here's your B cells, and then we're going to try to clean them. Again, this is the lymphocyte size cluster, but we don't want to clean these out because there might be something of interest over there. So you leave the larger cells in. There's not too much you can clean. Then this is the usual 45 versus site scatter. Again, the site scatter is a little higher than you normally see for lymphocytes. I'm gonna exact zap the white. And see, seems like there is a nice split into kappa lambda. So I would take some color, let's say blue, and go along the diagonal, and you have a kappa and lambda. Now notice here, the kappa is the cyan or light blue, it's around 30, and the lambda is 13, right here, green. So that is a ratio of more than 2:1. And what you may also notice is that preferential, so if there's a tumor, it's going to be in this blue population, right? And what you might also notice that the larger cells here are almost all blue. No green is represented here, or very little, hardly seen. And then as you go through the markers, you will also see, this is just an artifact, I'll clean it up. You can trust me that this particular thing belongs to this cluster of T cells. So I will clean that out. Okay. Then what else do you notice? Right here on the 20 versus 10, once you suspect something, you look at 5, 10, any aberrancy coming out. So you see this very nice cluster of CD10 positive cells, right? So if I take different color, let's say red, and overlay this cluster, whatever was cyan became white. Take the red, whatever little green was there in here, just that little smidge has become yellow. That's not so relevant. So now if you look at the remaining kappa lambda, which is the blue versus the green, that is 15 versus 13. So that ratio has normalized. And now we've brought out this white population right here that is all CD10 positive. I'm going to merge. It's a little bit of a junky specimen, can't really clean very well. But this is what that population looks like now. So some of this stuff probably also belongs there. So let's undo that. Okay. Red. And now I'm going to merge the white into a red to take a look at it. So the rest can go away for now. So we're going to exact zap all but the red. And let's take a look at this population. This population seems to have, so the lymphocytes were right here. This is probably representative of this population. And so you saw that the other B cells were here. In fact, you can get T cells as an internal control if you wanted, right? This is your lymphocyte cluster. These cells seem to be medium to large in size. They are monoclonal, kappa positive. So the next two markers you look at are 5 and 10. They're clearly 10 positive. You can take it from me that they were 5 negative. Remember, large cells have autofluorescence, this little stretch that you're seeing. So they were 5 negative, 10 positive. And so what is your differential? Well, it could be a follicular lymphoma, but because of this medium to large cell size, it's either maybe a higher grade follicular lymphoma, potentially a Burkitt lymphoma, although it's less likely, and I won't get into those reasons why, or this could just be a large cell lymphoma. So that's your another B cell tumor going down your algorithm. This is a CD10 positive example, but also made up of medium-sized to larger cells. Okay. Let's go on to the next case. Let's do something not B cells. So here's a good one to discuss. So this is a mediastinal mass. I don't have the rest of the history here, but let's see if we can find any good marker by which we can, okay, so seems like these are all T cell markers, and there's a nice cluster of CD5 positive cells. It seems to basically paint everything except for this CD45 negative chunk. So let's see if we just painted all of these. Yep, it's that same cluster. So almost everything in the specimen is CD5 positive, and this is in the mediastinum. So basically we have two different differential diagnoses between, is this a T cell tumor? More than likely a T-ALL, right? That's a common site. Or are these just thymocytes developing T cells? So here, almost the entire clue for you is going to come from two plots. And I'll display them. See, they're all CD7 positive. They're 4-8 is partial, but I will change the markers here to CD3. And CD1A, which in the context of a T cell is a marker of immaturity, right? So we clearly have CD1A expressing cells, so we know there are immature T cells here. So now the differential becomes between a T-ALL, T lymphoblastic lymphoma, versus a just thymocytes, so indicating either a hyperplastic thymus or a thymoma, something of that nature as the explanation for the mass. If this is a thymoma, we are not looking at the tumor cells. We are looking at thymocytes that are supported by the tumor cells. And the key thing to remember here is the word or the phrase spectrum of maturation. So what you're seeing here is a classic spectrum of maturation. Normal thymocytes start with this double negative thymocyte. Then in human beings, they actually form a single CD4 moderately positive stage, then move on to this common thymocyte, 4 and 8 double positive, and eventually mature into a single positive CD4 cell that had interacted with the MHC class 2, or a single positive CD8 cell that got selected on an MHC class 1. In the same way, for CD3 maturation, they start with 3 and 1A double negative. The most common stage within the thymus is a CD1A positive stage. As they gain CD3, surface CD3, when they put out their T cell receptors, then eventually they're going to downregulate CD1A and going to become mature CD3 that are sent out into the periphery to populate your immune system, right? So this spectrum of maturation that is seen tells you that this is not a lymphoblastic lymphoma. This is in fact just thymocytes, and this case turned out to be a thymoma. So it's a very nice representation of a spectrum. I'll try to pull out a T lymphoblastic lymphoma case for next time so I can show you how almost 100% of them will deviate from this spectrum of maturation. So we will do that next time. And right now, just remember this spectrum of maturation of thymocytes. Very rarely, I've seen just maybe 2 or 3 cases where this can get very, very confusing. But otherwise, the 4 markers that will help you clinch this typically Friday evening, Friday night differential diagnosis are CD3 and 1A and CD4 and CD8. So maybe we'll do one more case and then we will stop. Okay, going back to the top here. So this is a peripheral blood specimen. And right away you notice something's weird, right? There are no granulocytes, hardly any monocytes, just these two blobs of lymphocyte level CD45 and moderate, almost going into negative CD45. And then a very nice cluster of CD19 positive cells. So let's start there. So you have your lineage positive CD19, and the CD19 is splitting. Let's just clean it up. It's splitting into two populations. One has high CD45, so let's overlay that. Make it yellow. Take away the white and the red. And so one thing you notice there, let me put these away down here from the last time. Okay, one thing you notice right away is your predominant cluster here. Here, let me convert that to a red so you can see it. The predominant cluster here is negative for kappa or lambda, maybe streaming towards lambda a little bit, but not much towards kappa. And these yellow cells that are high for CD45 are splitting, some on the kappa side, some on the lambda side, and they all seem to be CD20 positive. Now there's a slight smidge here that doesn't really belong. So since I'm bothered with that, let's go ahead and those are your CD19 positive cells. I'm going to recall all colors. So you can, I breezed past that. You can actually go in and remember your analysis, remember the colors you've analyzed, and then recall them. So I remembered the red and refined the yellow and brought it back. That's what I did. So, so clearly most of the red population is CD34 positive. Some of it is not, but predominantly CD34 positive, kappa lambda negative, CD19 positive. So 34 positive tells you it is immature, right? So the differential now becomes, are these hematogones or is this a B lymphoblastic lymphoma? Now, first of all, this is peripheral blood. Secondly, not all, even if this was bone marrow, having everything CD34 positive is not the correct feature of hematogones. Next time, maybe I'll bring a case where we can go over hematogones in detail. Hematogones should be CD10 uniformly positive. Here, there's a variability in CD10 positivity. So again, that is aberrant for being hematogone. So putting all of that together, you would come to the conclusion that this is a precursor B cell tumor. This is a B lymphoblastic lymphoma. So in the interest of time, we will stop here today. And I will now see you next time where we will discuss a few more cases and then also go over how to formulate a report. So for each marker, how you will use terms to indicate aberrancy versus normal, things like that, so that there is some consistency in communication. We'll try to do that next time. So for now, enjoy going with the flow. Thank you.